Could start doing some introductions maybe while waiting. This is Sheldon, for anyone who hasn't met Sheldon. So I just want to, I'll thank everyone for joining our Nova Scotia EMS Journal Club today. We're excited to be able to critically appraise the study by Dr. Sheldon Cheskes and colleagues on defibrillation strategies for refractory fibrillation. I'm Judah. I'm the research coordinator and for Emergency Health Services Nova Scotia and an assistant professor within the Dalhousie Department of Emergency Medicine Division of EMS. And I think I just saw Sheldon join. So welcome,
Yes,
Sheldon.
I got it.
Wait to see if his audio is
I
connected.
made it, my friend.
Awesome. Thanks for joining today.
Yeah, no, for
I'm just
sure.
going through some introductions.
Yeah, that's great. No problem at all. It's looking forward to it.
Excellent. So then I also want to thank Jen Green for joining. She's an advanced care paramedic and paramedic emergency health services KT coordinator, and will critically appraise the paper for today. And quite excited to do so, I believe.
Yeah, I've been looking forward to this, waiting for this publication for a long time.
Yeah. And I'd also like to introduce Dr. Sheldon Cheskes. He's an associate professor within the Division of Emergency Medicine, Department of Family and Community Medicine at the University of Toronto. I'm a scientist at the Li Ka-shing Knowledge Institute at St. Michael's Hospital in Toronto, and medical director for regions of Halton and Peel, the Sunnybrook Center for Pre-Hospital Medicine, and also a principal investigator for the Canadian Resuscitation Outcome Consortium, CANROC, and the DOSE-VF trial that we're going to discuss today. And I'd also like to thank the EMC Clinical Services team for organizing the platform, and Evan especially, and Janelle and Daniel for providing their input. Great, we'll jump into this. So we have no conflicts of interest, but Jen and I are both contributors to the PEP website, the Pre-Hospital Evidence-Based Practice website, and instructors for the Dalhousie Paramedic Evidence-Based Practice course. The objectives for today are there's a couple of objectives. It's really to introduce you to discuss principles of evidence-based medicine and how to use the PEP website to inform your practice as a paramedic, and then also to critically appraise the DOSE-VF trial. And there are a number of observational studies on the utility of dose or double sequential external defibrillation. But these come with a number of known issues, which I'm sure Sheldon may touch on at some point today, and Jen. And Jen and I have been quite interested in this study in particular. We use it as an example, especially there was a case report published a number of years ago in 2016 on the use of this intervention. And we use this as an example of how research can flow from a case study to observational studies and then a randomized control trial. So this is a great example of this. And then I was listening recently to the Critical Levels podcast by Zach Ganter. And I think, Sheldon, you guys spoke about this case study. I was just wondering if you could elaborate on it a bit. We use it in our PEBP course, and it's great that it was brought forward by a paramedic, but I think you provided a few more details on the Critical Levels podcast that some people might be interested in here.
Yeah, no, for sure. First, everyone can hear me?
Yep.
Yes.
Okay, no, that's fantastic. First, hey, Jen and Judah, thanks so much for allowing me to come on your webinar today. It's I'm used to seeing faces, right? But I forgot this one, you can't actually see any faces. But yeah, I'm so pumped because I think Dal does a great job. Nova Scotia really focused on evidence-based medicine, and I think this will allow us to talk about some of the evidence around the area of double sequential. So I think how we got interested in the area of double sequential was really a single case. It was a 28-year-old female who was 1 month postpartum, and she went into refractory VF, so she had 5 shocks. And the paramedics had heard me talking about the concept of double sequential. There've been a couple other case reports, and they made the first ever patch to Sunnybrook to use DSCD. was so funny because the patch didn't really know what DSCD was, but they said if Shell's talk about it, let's do it. They used DSCD. Patient got Rost and survived the hospital discharge to take care of her 1-month-old baby. Now, in my experience, that would have been a patient who likely would have died otherwise. I said there's something to this. I think we need to look into this more. I think this is a strategy that could be effective in refractive VF. So that little one case study stimulated what we then did was a cohort series where we compared DSCD used ad hoc to standard care. When we did ad hoc, we but when we looked at the timing, we found that the earlier you did it, then you did see benefits with respect to ROSC, and that allowed us to sort of come up with a protocol for dose VF that focused on doing DSCD as early as possible. So for me, it all started with that one case, and that led to 8 years of research after that. So it's pretty crazy when you look at this. Yeah, 2016 it was published. So yeah, pretty well 7 years of research after that one case report.
Pretty amazing. And it also shows how paramedics can really get involved in research and kind of lead to change in care. Okay, jump forward. So the goal for today is to really focus on evidence-based medicine. And we need to know as paramedics how to critically appraise research to be able to apply it to our practice as paramedics. So the goal is to really work in this area of clinical expertise where we're bringing in what we know about the clinical state and circumstances, what we learn in school, patients' preferences and actions, and then also research evidence. So we need to be able to critically appraise evidence. We're really focused on 3 questions. Is the evidence from the study valid? If it's valid, is it important? And then if the evidence is valid and important, can we apply it to our patients wherever we might be practicing? So this is the study we're going to discuss today. And, just jump forward and I'll turn it over to Jen to start the critical appraisal.
Thank you so much. One can say I'm amped to do this journal club. That. Okay, so let's get into a little bit of the background of why this is so important. There are about 350,000 cardiac arrests each year in North America. Many of these are VFVT arrests. These patients have better chance of survival than other rhythms, and about half of them remain in VFVT. They remain refractory to defibrillation attempts. And herein lies an opportunity to improve our care for these patients, and so that they do have a better chance of survival. And I think it's really remarkable how a case study that happened because somebody had the conversation with you, Sheldon. They learned about the evidence and they patched it in and they saved this woman's life. And that was published as a case report. And ever since then, in the past 7 years, there's been observational studies and comparison studies. And then, of course, your team took it on to do the large randomized trial that is the dose VF trial. And I'm so happy to be reviewing this here today. All right, let's move into the interventions there, Judah. So it was proposed that these 2 defibrillation strategies, vector change and dual sequential, could improve outcomes for these patients that are refractory to initial defibrillation attempts. Sheldon, would you walk us through what these 2 strategies really are?
Yeah, for sure. So basically, what happened in this trial was patients who had to present in VF or pulseless VT and then have 3 shocks in a row separated by 2 minutes of CPR and still be in VF at analysis 4. So basically, these patients had to be, for all intents and purposes, VF, 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 and still be in VF at rhythm analysis 4. Importantly, so anything else was excluded. So if you went VF, PEA, VF, you're excluded. VF, VF, PEA, you're excluded. VF, asystole, VF, all those were excluded. So you had to, these we felt were going to give you the most refractory patients. So the first strategy was all the pads in those first 3 shocks were pads in the standard AL position. Okay, so after the first three shocks, the pads were removed from the AL position. AP pads were placed, otherwise known as vector change defibrillation. So that was one strategy. The second strategy had AP pads applied to the patient who already had AL pads in place, and rapid sequential shocking in two defibrillators, otherwise known as DSCD. So again, shocking was sequential, not simultaneous, and the pad position or changes occurred after the third shock. So a very critical part of the study is to make the interventions early as opposed to late, because much of the observational research was tainted in the past. When people did DSCD, they did it as a last-ditch effort when everything else fails. Well, when you do something as last-ditch, it's most likely going to fail. And that's what's happened in previous observational research. So our focus here was to do the interventions as early as possible.
That's excellent, and I think it's really cool that we've come full circle, because I think you were invited onto a dual sequential journal club that we did probably 4 or 5 years ago, prior to the dose VF trial being conducted, where we talked about those exact limitations that the observational studies had experienced before, and you guys have gotten beyond those to get much more valid data. So that's really cool. All right, we'll move on to the study objectives. The objective of this trial was to evaluate the dual sequential and vector change defibrillation as compared with the standard defibrillation in patients who remain refractory, just like you described. So VF, VF, VF during the out-of-hospital cardiac arrest. And there were some primary outcomes, which the primary outcome was survival to hospital discharge, and then some secondary outcomes that were reviewed. So the secondary outcomes included termination of VF, defined by the absence of ventricular fibrillation on subsequent rhythm analyses after defibrillation, and 2 minutes of a CPR interval. They also reported on return of spontaneous circulation, defined as any change in rhythm to an organized rhythm with corresponding palpable pulse or blood pressure documented by paramedics, and survival with good neurologic outcome at hospital discharge. This is defined as the modified Rankin score of 2 or lower. So the score would range from 0, which is no symptoms at all, and 6 being death. And I really was pleased to see that we looked at really important two-patient outcomes in this study. I thought that was excellent. In terms of design, this is something that I'd really like Dr. Cheskes to elaborate on. Sheldon, can you tell us a bit about the design and how this study was rolled out?
Yeah, so that's key. So the study was it was a cluster randomized trial with crossover in 6 paramedic services. So just so people understand cluster randomization, when you randomize patients in a particular study, there's multiple different ways you can randomize. You can randomize at the level of the patient. So you get to the patient, you open up an envelope, it says what you're randomized to, or you can do cluster randomization where the whole service does one intervention for a time frame. And that's what we did in many previous ROC trials. That's what our services were used to, and that's how we did this trial. So, for example, Peel Region, they would be randomized for 6 months to DSCD. So all the patients who met the study qualifications would get DSCD for those 6 months. After that, they would be re-randomized to a different strategy, and we would inform the service 2 weeks prior to their crossover what they were going to be randomized to. So from the paramedic point of view, it made it as simple because they got those patients over that 6 months. They were always doing the same strategy, and we did that in all of the 6 different paramedic services. One of the ways we tried to inform paramedics to make sure they did the right strategy is we put labels on the defibrillator during those 6 months that said DSCD or VC or standard. So they knew what they were in from those 6 months because of those labels, because of the information we imparted. We also used signs at the services so people knew what they were in. And that's the key to cluster randomization. So each service that took part, there were 6 services, some took part longer than others, but to be part of this trial and to complete the trial, everyone had to spend a minimum of 6 months in one of the arms of the trial. So Ottawa was the last arm in the trial. They spent 6 months in each of the arms, whereas Halton was the first off in the study, and they had 6 crossovers, so they spent a number of times in each randomization. But cluster randomization, you do the same thing for each patient over those 6 months, as opposed to randomization at the patient level, which I think is much more difficult for the paramedics. I find when you randomize at the patient level, the paramedic, if they're really interested, they just keep opening up envelopes till they get the one they want.
Are there any other things that, like, lessons learned from doing crossovers,
Yeah,
like in terms of?
I think what you're going to do when you do a randomized trial is do what your paramedics like the best. So to me, this is something they were comfortable in, something that they had done previously before. Occasionally, you may get some issues at crossover time, but we really, really focused on that. And when they crossed over, they never crossed over to the same intervention. They always went to a different intervention. So I just think this is again part of running a randomized trial. Make sure you speak to your paramedics and make the study as easy as possible for them. The beauty of this study is not only did we train 4,000 paramedics, but I've never done a trial where there was so much buy-in to the study by the paramedics. And people say, Shell, why was there so much buy-in to the study? Well, one is involve everyone. So this study took place with both ALS and BLS paramedics. Two, I think there's a bit of a cool factor, using 2 defibrillators, that was pretty cool as opposed to other studies where you're giving a little bit more, a little bit less medicine. We've already done that. That didn't interest them as much. But the biggest thing that interested them, folks, was, you saw an immediate effect of your intervention. So you did DSCD, the patient got ROSC, and he said, shit, that never happened before. And it really made you think that, hey, this is going to work. And I think in retrospect, I get now at least an email a day from a clinician around the world who's using this, who say, hey, I did this and it worked. Thank you so much for your research. So that's how it kind of built. And I think it built like that for the paramedics.
Just a question from the chat. Was there in-service training up front prior to the first
Excellent
randomization,
question.
or between?
100%. So we did in-service training for all ALS and BLS paramedics. It was 2 hours in service, where we went through the choreography of DSCD, how to do it properly, trained them on the background, and then there was a lot of interaction between the paramedics and the PI. So after each case, we contacted the paramedics, talked about any challenges they had in doing it, because you can imagine in real life, it's not the same as doing it in a training room with sim. And there was a lot of little nuances that we learned from the study. So the training was consistent for everyone, as was feedback that we provided to the paramedics.
And from what I understand, there was a pilot done prior to the larger study to ensure that this was feasible.
Yeah, and I would, in terms of study design, Judah and Jen, I would probably never do an RCT without a pilot. I think a pilot lets you see if you're going to succeed or fail, lets you figure out the fine nuances. And really, the only major change we made from the pilot to the RCT is we included fire shocks in the RCT. So in the pilot, we found that ROS rates were higher in vector and double sequential, but we didn't count fire shocks. So you could imagine you had to wait 3 shocks. If fire had done 2 shocks, by the time you did an intervention, you're already at shock 6, which kind of defeated the purpose. So we thought that the pilot may have underestimated the benefit of the intervention. And therefore, we decided when you look at the patient level, we didn't care if fire EMS gave the shocks. We just wanted to say, did this patient get 3 shocks? Once they did, let's do an intervention. So I think the inclusion of fire shocks was the only major difference between the pilot and the RCT.
Fantastic. Okay, so let's discuss who was included and who was excluded from this study. And I always find it so important when you're looking at your results, who was your sample, because you have to study who you intend to study. So all patients that were at least 18 years of age and had an out-of-hospital cardiac arrest with refractory VF of presumed cardiac causes were eligible for the trial. Refractory VF was defined as initial presenting rhythm, like we've discussed, of VF or pulseless VT that was still present after 3 consecutive rhythm analyses. Um, and then for who was excluded, so those that were not going to be included into this trial, they were patients with traumatic cardiac arrest, those with a DNR, patients with cardiac arrest due to drowning, hypothermia, hanging, or suspected drug overdose. And the reasons for that were because the etiology of an arrest is much different than a normal medical arrest, or who you would normally come across. And interestingly, this study did not exclude pregnant patients, which is typically done. And I know that that was a very specific request. Sheldon, can you comment on that and how the patients were selected into the trial by paramedics?
Yeah. So the pregnancy one, I think, was a direct result of the case report. That patient was 1 month postpartum, survived. That was a direct request of the REB to include. Generally, you exclude pregnancy prisoners in pediatrics. That's kind of common in cardiac arrest, but pregnancy was a specific request of the REB. I think it was mainly because of the fact that of that case report. In terms of exclusions, as soon as the paramedics counted 3 shocks, the patient wasn't going to be included in the study. Now, there were patients who were excluded because when we reviewed these cases, we reviewed all the defibrillator files because we wanted to make sure that the patient actually had 3 shocks. And on occasion, you'd find that in fact the patient went VF, VF, PEA, VF. So we excluded those particular patients because they clearly didn't meet the inclusion criteria. So generally, again, any patient who by the paramedics felt that they had the first 3 shocks, they were included pending review of the defibrillator file.
Terrific. So we know what the interventions are, we know who we're applying them to, and now we'd like to discuss how these interventions were applied. All paramedics followed a provincial protocol consistent with AHA guidelines for the treatment of patients with VF. Continuous chest compressions were performed before the application of the defibrillator pads. And I understand that there's a specific choreography to this pad application, and Judah has some links there, which we'll provide for all of you so you can understand the choreography that goes into this, especially when using a mechanical compression device. Shell, would you explain a bit about this choreography and how the paramedics found this process?
Yeah, so that's cool. This is the most important part. And I can tell you when New England looked at this, they were most interested in the videos because I think it allowed the reviewers to understand exactly what was being done when we did DSCD. So essentially, the patients went shock, shock, shock. After the 3rd shocks, we did 30 compressions, 2 ventilations, log rolled the patient, placed the posterior pad. We then did 30 compressions, 2 ventilations, place the anterior pad. We then did a full minute of CPR and applied a shock sequentially if it was DSCD or a single shock if it was vector change. In that process, what we found was that process minimized interruptions in CPR. We spent a whole day with our instructors trying to find the best way to do this, and this was a technique that we use consistently throughout the trial. And you can see, and we'll probably talk about CPR quality, the medics were able to do this while maintaining guideline compliant CPR quality, which was really critical, I think, to the study's success.
I've included a couple of links. I'm not sure if are the videos behind the paywall for the New England Journal of Medicine, and if
I
so,
think, I think it
also
is. I'm
yeah.
happy to share. We've got a whole bunch of brand new videos because the videos were such a hit. We have videos with AEDs in manual, manual and manual, mechanical. Like we have every combination you could imagine. I'd be happy to share it with your group after because I think they are on a firewall.
Awesome. I found one at the GEMS website that looked like it was from your group, but so that's up there as well.
Amazing. I can't wait to see those. So in terms of results, this trial had enrolled 405 patients before the study had to be stopped. And we'll talk about that stopping a little bit in a moment. 136, so 33.6 were assigned to the standard group, 144, so 35.6% to the vector change group, and 125, so 30.9% to the dual sequential group. The mean age of the patients in this trial was 63.6 years, and 84.4% were men. And initially that's surprising, but it does make sense given the pathophysiology of someone who may be in refractory VF. And so we see here that the important event characteristics were similar in all groups, which is exactly what you want to see in a randomized control trial. This means everything is working exactly as it should. Okay, and now next, we're going to be looking at the CPR metrics. So this was really cool that you guys had the insight to report on CPR metrics. It's something that we always wished for in the previous observational studies on this particular intervention, and I'm so happy that you guys reported on this. So quality CPR was maintained throughout. Sheldon, do you have any commentary on the application of CPR and how important the high quality CPR was in this context?
Yeah, I think it's critical. So you may have a lot of interventions in resuscitation that sound great, but if the pre-existing CPR is shit, the intervention won't work. And I think that was a characteristic of every previous observational study. No one commented on CPR quality. And one of the biggest questions people had when we went into this study is, can you do these interventions, log roll patients, etc., and still maintain high quality CPR? And we knew we could based on our choreography. And really, when you did that log rolling, turning the patient, the amount of time it took to do that was less than it takes to put a mechanical CPR device on. So you can see all the CPR quality was guideline compliant. Our services have always measured CPR quality for at least 20 years now, or ever since the ability to measure. And we've always had really super CPR quality, and it continued in and made a big difference here. I'm just going to make one other comment, Jen, because you touched upon it about the focus on males, 84% of males. So why does that make sense pathophysiologically is because the success of defibrillation depends a great deal on transthoracic impedance. Males are generally bigger, more cardiomyopathy, more hypertension. All those things make defibrillation more difficult. So it's not surprising to me that the high proportion of patients were in fact males. You may as well have noticed in that previous slide that the rates of bystander CPR were in the 60% range. When I first started out here, our bystander CPR rates were 30%. So to see that rate of bystander CPR, I think was really, really encouraging.
Yeah, absolutely. And thank you for delving into that with some more detail there. Perfect. Okay, so in terms of outcome results, right, what we've all been waiting for. Okay, so 13.3% survived in the standard group. All right, that's just the normal defibrillation. Now, 21.7% survived in the vector change group, and 30.4% survived in the dual sequential group. So to put that in perspective, patients had nearly twice the risk, so to speak, of survival when receiving vector change compared to standard, and over twice the risk of survival when receiving dual sequential. And these are statistically significant differences as well. So in terms of the secondary outcomes, dual sequential performed significantly better in each outcome compared to standard defibrillation, and vector change was significantly better than the standard for survival to discharge and termination of VF. And these are just really fantastic results. We're really happy to see this. And I remember when you were in Cape Breton, you presented some preliminary results that were alluding to what you were hoping to find at the end of this trial. Do you have any other commentary about these results and how fantastic this is?
Yeah, I still remember Cape Breton. I love Cape Breton. As you know, my wife's from Nova Scotia, so I have a special place in my heart. And I still remember giving that talk in Cape Breton and how in tune the paramedics were. They really were into their pre-hospital care. It was a memorable conference for me. I think the key here is that you have two interventions now that appear to be better than standard care. And really, when you look at cluster randomization, unadjusted is cool. You really need to look at the adjusted values. And I think here, the fact that DSED was superior, but it was superior in all primary and secondary, vector change, the point estimate, as you see, is not quite as high as it is for DSED, not as consistent outcomes with respect to neuro intact survival. And we'll talk a little bit later. People talk to me about double sequential vector, which one would you do? And I'll give you my sense of that one based on the study findings.
Sheldon, just a question that came in as well, more to do with the last slide. Were any of these services using mechanical devices, or was the study limited to traditional hands-on CPR?
Yeah, so 3 sites use mechanical CPR, but it's sort of like mechanical CPR at the time of the intervention. So it wasn't like they did mechanical CPR, stopped it and put on the pads. We have a specific mechanism by which you do it. So when you put the posterior plate on, you're putting the posterior pad on at the same time. And we have video showing that. So 3 sites did mechanical CPR, 3 sites did regular manual CPR. So we did have mechanical as well in the study.
Great, thanks.
That's terrific. And I know that that'll be interesting to many of our Nova Scotian attendees here. We've just recently started using mechanical on for some of our cardiac arrests when it's available. Amazing. So in conclusion, survival to hospital discharge appeared to be higher with dual sequential and vector change defibrillation. So both of these strategies do appear to be better than standard for patients with refractory VF during out of hospital cardiac arrest. So, of course, because this is a journal club, we're going to get into a little bit of critical appraisal and discuss some of the strengths and limitations of this trial. All right. So fortunately, this trial had many, many strengths. The authors employed a very robust design. They randomized and crossover treatment, which is, we talked about that and the value in that. And they measured CPR quality throughout the trial, which remained very high. They measured outcomes that are important to patients, such as the survival neurologically intact. Amazing. And the outcome assessors were blinded to the treatment assignment. So this could reduce the risk of bias in the interpretation of results. So although you can't blind to whether you're receiving a certain defibrillation strategy at the level of the patient or the paramedic, the team were able to blind the assessors of the data. So that's a terrific addition that they did there. In terms of limitations, there will always be some limitations, and unfortunately, this trial was subject to unforeseen challenges due to the COVID-19 pandemic, and this resulted in challenges with enrollment, and ultimately the trial had to be stopped or was recommended to be stopped by the safety board related to COVID-19. Sheldon, would you mind commenting on this and its impact, if any, on the strength or interpretation of these results?
That's a great question. So someone asked you how close did they get to the power calculation. So I'll talk about power in a second and number needed to treat. It'd be really cool because I have some slides. I had a whole Dalhousie grand rounds ready for you guys, but I have some slides that can answer these questions. So I think they're great questions. So first of all, why was the trial stopped? So the trial was stopped at the concerns were expressed to the DSMB late 2021, late 2022, early 2023, late 2021, early 2022. At that point, Omicron came about. So what happened when Omicron came about, I'm not sure if it was the same in Nova Scotia, we had essentially 50% of our workforce off with COVID or with COVID contact. The other 90% of those 50% were an offload delay. So we had services randomized to DSCD or vector change. By the time they got to the patient, our first responder had given 5 or 6 shocks prior to EMS getting there. So in my history, the most you'd see of fire shocks is maybe 1 or 2. 5 or 6 was unheard of. So at this point, you're providing the intervention, DSCD or VC, at shock 6, shock 7, exactly mimicking previous observational research and therefore making the trial protocol impossible to carry out. And that's why the DSMB stopped the trial. So importantly, they stopped the trial for feasibility. The trial was not stopped for superiority, and superiority is when you usually get the overestimate of the effect size. So I think the feasibility piece was key. That's why the trial was stopped, and it was done with good reason. Listen, if I knew, and I can give you some insights into what we're doing now, if I knew that COVID was coming, we would have taught our fire services vector change. And in fact, that's what we're doing right now because we know there are delays in response time. By teaching our fire services vector change, once the paramedics come, they simply need to put 2 AL pads on and they're ready to do DSCD. So again, I think the important point there is it was the scenario and the situation that impacted the study stopping. It wasn't superiority because we knew our results because we didn't know our results. Our results were done through a linkage with CHI to get our final outcomes. We had no idea what the outcomes were going to be. So feasibility stopping as opposed to superiority. 90% assignment adherence. I think that's damn good in a tough, pragmatic pre-hospital care trial. And there was not one paramedic who wanted to do the intervention. I think that's very key. But when you write a protocol for pre-hospital care, you have to remember we thought it was going to be 3 shocks, and shock 4 was vector change or double sequential. But you know, paramedics, you get in a situation in a basement, in a ditch, on a bus. We had all these. It wasn't possible to do the actual intervention at shock 4. A standard shock was given, and that's what causes the protocol compliance issues that we see. It had nothing to do with paramedics not wanting to do the intervention. It all had to do with the environment the paramedics were working on.
Absolutely. And 90% is excellent. And, you know, all of us on the line have had that arrest in the tiny bathroom. And so we understand the complexities of the pre-hospital environment for sure. And then
Just a question about the adherence, and this relates to like our previous conversation, but
yeah.
were most of them due to a barrier, or were some kind of related to that crossover and changing?
No, they were all every patient of protocol compliance was related to a barrier in providing the intervention. Not once did a paramedic not want to give the intervention. And
Fantastic.
that's really important. See, this is the beauty of these are the nuances you guys are going to get through today's talk that you can't really get through a 2,700 word article in New England Journal. And these are the fine, and especially because you have paramedics there, they get it. Do you know what I mean? You've all been there and seen those particular scenarios, right? So I think it makes sense for paramedics. And I think one question came up. I don't know if you want me to address this now, the idea of power. Do you want me to address that now, or
I
Jen,
think
do you
so.
want me to wait?
Sure. We're on the sample side, so may as well. Yeah. Great
Yeah,
question.
yeah. So people often think that if you don't finish a study in the sample size you get, that your study is underpowered. So I'm here to tell you that it makes no sense. That actually is not a true comment. So whenever I see blogs and bloggers say dose PF was underpowered, you know they don't know what the hell they're talking about. So power is an interplay between sample size and effect size. And the effect size predicted for this study was 8%. But the seen effect size for DSCD was 17.1%. So it blew the effect size out of the water. If you did a back of the envelope calculation with that effect size and the power, the number of patients you would have needed would be about 300 patients. So in fact, this study was not underpowered because the effect size was so large. So I think that's really important to understand. And adding to one of the questions that I saw pop up, if you look at that effect size and try to translate that into a number needed to treat, the number needed to treat for DSCD is 6. That's ridiculous. That's like ASA and STEMI. The number needed to treat in vector change is 12, which is also superb. But number needed to treat of 6 for DSCD is beyond what anyone could have imagined, and probably one of the biggest surprises of the study.
That's terrific. Would you mind just defining NNT for those that maybe aren't familiar on the line?
Sure. So
Thanks.
NNT is 1 divided by the absolute risk reduction. So the absolute risk reduction here was 30.4% minus 13.3%. And if you bring out your calculators and do 1 over 17.1, that's where you get 6. Similar type of calculation for vector change.
And that sort of brings the stats to life, really, I think.
Yeah.
It's really amazing. That's an amazing number. Okay, let's move on to generalizability. So we're looking at, we're from Nova Scotia. Many of you may be from outside of Nova Scotia on the line. The results of the study do have generalizability to our service here in Nova Scotia because they applied the intervention in urban and rural settings, and the intervention was conducted by both BLS and ALS providers. Now, the majority of the calls had ALS, from what I understand. And my other question here for you, Sheldon, is how rural is rural? Because Nova Scotia has long response times in many cases. Maybe Sheldon and Evan, can we discuss how this would translate to our patients in our province?
Yeah. So rural for us, there are areas in London that were rural, patients in north area of Peel, like Caledon, which we consider rural, areas of Ottawa that we would consider rural, but there's that rural and there's Nova Scotia rural. Okay. So Nova Scotia rural is a different animal. Okay. And so where I see vector change making a difference is in those rural services where you have nothing else to do. So to me, I think the days based on dose VF, based on the arrest trial with ECMO, the days of continued standard shocking when standard AL pads are in place, I think those are gone. And I think the new ILCOR guidelines will reflect the findings of dose VF. If I'm in a rural setting, I would definitely do vector change. But the other thing I would consider is a defibrillator on the truck, much cheaper, and therefore have the capability of doing DSCD in some of these areas with an AED and a manual defibrillator. So that's some of the things we've thought about for rural agencies, but no question I would do vector change as opposed to just continued standard intervention. I think Jen and Judah, one of the biggest highlights for this study was having the BLS paramedics involved. Like I know for sure every place you're going to have more BLS than ALS. They love to be involved in something like this. And just to focus on, again, you don't see this in the paper, but I'll tell you, we had 8% of patients who had BLS care only. No IV, no antiarrhythmic, no epinephrine, no advanced airway. And they had a 50% survival rate from refractory VF in the study. Now that's insane. And that tells you that the key to refractory VF is not drugs, it's defibrillation. So I think that really juices up the BLS paramedics and say, man, I want to take part in this because I can make a difference even without the drugs.
Yeah, you hit a lot of the high points there for sure, Sheldon. Definitely, we're rural here, mostly in Nova Scotia. We do have a fair bit of BLS, especially in rural, and really the only place that will get ECMO will be somebody within Halifax going to the queue, and even then that might be limited. So for those persistent VFs, this is potentially a game changer. It's not in our CPG now, of course, but down the road, definitely could be something that would definitely benefit rural residents of Nova Scotia.
Yeah, and just a comment that I saw in the chat box. People may have noticed just March 2nd was my birthday. You don't know that, but I'm just telling you. And we responded to a letter of the editor. We had 4 letters to the editor in New England Journal. And one of the comments that the individual made is this is not applicable because it was done with manual defibrillators. We sent in, and you can see the video of this, and I'll be happy to share it, you doing DSCD with 2 AEDs. Now, how cool is that? Okay. So
Very cool.
any combination we've thought of already, and we have videos showing how to do it. So this, I think, improves the applicability. And with respect to the standard and what the standard of care will eventually be, I think ILCOR will guide that, but there's no question the draft recommendation from ILCOR is supportive of the dose VF in using DSCD as opposed to standard care. I think significant oversight, yeah, we did have significant oversight in the study, but we're still doing this now, and we still have paramedics who are really well versed. But listen, there's a training. There's no question. I just before this talk, I gave grand rounds at Sunnybrook, and the issue is this came out of a randomized controlled trial with well-trained paramedics. I do not believe it's possible to just go out there and throw 2 defibrillators on and say you're doing DSCD. I think paramedics have to be trained as we were trained. They have to have specific choreography, and they have to focus on doing the intervention as early as possible, because it's not done that way, you may not get the same results that we got.
What do you?
And
Just,
Oh, go
oh,
ahead.
sorry.
Eric.
I was just going to say, Sheldon, on that point, another question that popped up is, are there any manufacturers working on making defibrillators that are capable of one device doing dual sequential
Yeah,
defibrillation?
great question. So people ask me what was the greatest challenge of this study, and the greatest challenge was the defibrillator companies. Okay, and the greatest challenge maybe, and people may know about this, is that Stryker had a letter out to all their EMS services that if you damage a defibrillator during DSCD, they weren't going to cover the warranty. Now, the issue is these defibrillators are quite expensive, and we had 3 sites that were Stryker sites. So myself and Paul Dorian had to go to them, and we actually went to the EMS directors and said, using our technique of sequential DSCD, so one person pressing the shock button on defibrillator 1 and defibrillator 2 in a sequential manner, there was 0 chance of damaging a defibrillator via an EPS mechanism. And thank God those EMS chiefs said okay, and they allowed the study to happen. Because if they said no, we think you can damage a defibrillator, dose VF would have never happened, because half the sites were actually Stryker sites. With regards to one defibrillator, the defibrillator companies now, they weren't so hot on dose VF before. Now they're very interested, right? And the issue about putting the ability to do DSCD with one defibrillator, the issues that I understand from an engineering point of view is the size of the capacitors within the defibrillator. To do it, the capacitors would have to be large enough that would make the defibrillator just too heavy. Now, that's what we're seeing now, but who knows what the future will hold. So I think right now the focus is still going to be DSCD with 2 defibrillators. But again, as I said, we have many combinations from which this can actually happen.
Just that we started talking about ILCOR prior to this journal club, do they continuously update the guidelines now, or is it every 4 or 5 years?
Yeah, no, so ILCOR reviewed this right after the study came out, because they knew there was going to be a lot of interest in it. And the draft guidelines suggest the use of DSCD or vector change where feasible. Now that is going to come out officially, and I think that's when you're going to start seeing more uptake around the world. But I have to tell you, I've given probably 100 talks now around the world on dose VF, and the vast majority of agencies are switching their interventions. We're seeing this across Canada, so I've given many talks across Canada, and many either have already switched or are in the process of switching. And that's what we're seeing in Ontario. When the ILCOR guidelines are come out, we're going to expand this to the sites that weren't involved in the research. The sites that were involved in the research were given the go-ahead to continue doing the protocol when the paper came out.
This might be a good thing to bring up right now, Judah and Jen too. Speaking of that, so this doesn't change our practice here in Nova Scotia. We still have to follow the current cardiac arrest CPG, which came out in 2020 when the study was being done, of course. But going forward, when that we're looking at the new ILCOR recommendations, we're looking at changing that CPG. How can paramedics drive change in practice here in Nova Scotia and through things like the PEP program?
That was for Jen and I.
Yeah, yeah. Yeah, and how does the PEP program affect how Dr. Travers and his group might make changes to the CPGs?
Do you
Well,
want to tackle that one, Jen?
Well, the Division of EMS, which hosts the PEP program, are heavily involved in the CPG development program and that process. And we operate as evidence evaluators and appraisers, and we supply evidence for any of the interventions that we may be interested in changing, or we can propose changes to our CPGs from our perspective from the PEP program. And I think on the next slide here, we see that this study is going to be is in PEP, and you guys can read it and link to it through there. Now, don't cancel me,
We do.
Sheldon.
Yeah, we have some old rules within PEP
Well,
around power.
yeah, so with the rules of how we appraise within PEP right now, there's significant weight put on power, and where we didn't meet it in this particular study, it would be a level of evidence 2 out of 3, but in the future, we have some methodology changes coming with the program that would address things like power more specifically, and this would qualify as one of the higher levels given the robust design that you guys have employed. However, it is supportive for dual sequential and vector change within refractory VF within PEP. And as all of you know who use the PEP program within your CPGs in all sorts of different provinces across Canada, ours in Nova Scotia directly links into the PEP program, and I know plenty of other provinces do as well. For example, British Columbia links directly to this program as well. So that's how I see this program driving change. Sheldon, my question was, I'd like to see something like this be available to the paramedics in this province. What do you see as being the biggest potential delays or barriers to implementation of something like this within a province that hasn't adopted it yet?
So I don't think there's a lot that, I think there's the issue of training, but training really, there's not a lot of training, it's a couple hours and probably some early insight, early feedback to the paramedics on cases. There may be some who still have issues with respect to damage of defibrillators from an agency point of view, but we have evidence, and we published a survey of everyone who responded anyway, who was doing DSCD, and we found the damage rate of defibrillators using it at about 0.2%. So it's almost unheard of. In the cases that it was always simultaneous DSCD. We didn't find a single case of sequential DSCD causing damage change, and we feel that's 100% correct based on an EPS mechanism. The only way you can damage a defibrillator theoretically is pressing the button simultaneously to the millisecond at the same time, and therefore directing energy to the defibrillator as opposed to the patient. It's almost unheard of, and that's why it's rare. But I think for some, if there's some sites, that may be an issue. But I think that's the biggest ones. I think some will wait for ILCOR as well, but the vast majority of places that I've spoken, many of these people were doing it before the study even started. At least now there's science to support this. So I think a lot of people, once they saw the ROSC rates from the pilot study, they said, well, you know what, this is going to be positive. We feel, although there's many studies where ROSC is positive and survival is not, many people were doing it. I must have had at least 50 to 100 EMS agencies contact me prior to the study completion on how to do this the right way because they were already doing it. So I think this is one of those where ILCOR may make a recommendation, but there's a lot of smart people out there and they'll make their own recommendations and they'll have to answer that question. If that's my mother or father on the floor in refractory VF, do I want to just do standard DSC standard or do I want to give them DSCD or vector change? I don't think that's a really hard one to answer after this study. But again, there are some who, there's one RCT, and one RCT sometimes is not enough to change practice. But I would challenge those who think that way to, if you think that way, go ahead and do the study. And I haven't had one person out there who's ready to tackle dose VF2. And if I was going to do dose VF2, the study would be double sequential versus vector change head to head. The aim of this study was double sequential and vector versus standard. We would have never been powered, and the study should not be interpreted as DSCD is not superior to vector change, because that was not the focus of the study, and we're not powered for that particular question. But that would be a good study to do. We figured by calculating, it takes about 1,000 patients to do that study. I don't think we've got a lot of people who are interested in doing that work again when they have a strong finding in this study. So I think those are some of the things: fibrillator, one RCT, training. Those are kind of the big ones I see, Jen, to moving things forward.
That's great. And
Just trying to pay attention to time. Maybe I'll move us forward. Go
yeah,
ahead. Jen.
sure. So bringing it all full circle to the three main questions we always want to ask ourselves during a critical appraisal of a study. Is the evidence from the study valid? Yes, the study was incredibly well conducted with many strengths, and actually the strength to show causation. So that's important. Since it is valid, is it important? Yes, absolutely important. We know that good CPR, early defibrillation are keys to survival. And now we have another tool with dual sequential and vector change to make this piece even more successful. And these results, since they are valid and important, can they be applied to our patients here in Nova Scotia or wherever you may be joining us from? That is up to you to make that determination. But like the things that we've discussed, whether it's vector change or dual sequential, these interventions can be applied to our patients, and defer to your clinical services team for how that will work and look for the future of your practice within your province. And I just have some discussion points here. I know we only have, we don't have any time left really, but I was particularly fascinated by the increased energy and shock conditioning, but I'm not sure if we have time to talk about that or maybe address some other questions that have come up within the chat.
Do you have to jump off the line, Sheldon? Are you?
No, I'm here. I have another rounds to give at 3:00.
Oh, really?
What I've seen is there's 110 participants and no one's left. So I'm ready to keep talking as long as you guys, because I find this great. And these are great questions. Before I address these two, let me give you the sort of an overall uptake. And people ask me, is this ready for prime time? And really, the prime time question is related to science and it's related to evidence. And I know Lori Morrison, one of my mentors when I first started, said, Sean, when you do a randomized trial, do your best science and let that science speak for itself. And in my mind, there's no question this is the best science with respect to the area of DSCD. People will then judge that and make a determination. People ask me, if it was me, would I do DSCD or VC if I had a choice? And we feel that the findings strongly support DSCD as the first choice. If you look at the point estimates, if you look at the consistency of the finding amongst multiple sensitivity analysis, but also a number that's not often talked about, Jen and Judah, it's the fragility index. So the fragility index is how many patients need to have an opposite outcome to make your results go from positive to negative. So in DSCD, the fragility index was 8, which is very, very high for an RCT. In vector change, it was 1. So only one patient had to go from a survive to not survive, and vector change would have been non-significant. So I think those are really important to think about. I do not equate DSCD and vector change to be the same. I think that double sequential is a stronger intervention, but vector change to me is better than what you get with standard care. In terms of the mechanism, to me, when you look at biological plausibility, you really need to think about the position of the left ventricle in the thorax. So the left ventricle is really a posterior structure. And when you put even great AL pads in place, you miss about 50% of the ventricle. And when you go to vector change, you incorporate a portion of the ventricle that was missed by the previous standard AL shocks. And I think that's a real reason for vector change to be effective. With respect to DSCD, we think you get a much more homogeneous distribution of current across the ventricle. We also feel that the waveform of VF after the first of two DSCD shocks is much different than the original VF waveform and may be more susceptible to the second shock. But the thing we're working on as our secondary paper is we saw a characteristic 15 to 20% drop in impedance in the AP pad of vector change and the AP pad of DSCD compared to the previous failed standard AL shocks, suggesting that the amount of current through that AP pad was much greater than the previous AL pad. And when you talk about defibrillation, current is what matters. So there's plenty of mechanisms. We're doing our secondary analyses of the paper now to really delineate that for people. So we think, yes, vector is important, but some people, there's no question, you need more energy for sure.
If we have any questions or comments in the chat or Q&A. I see one question related to PEP from Russ that I don't, Jen, you might want to tackle, but we will be reviewing older articles when we do update the PEP website and methods. And there's over 3,000 articles now in PEP, I think. Is that correct, Jen?
Yes.
Yeah, I hear that this is a very good question. Why did we title it Defibrillation Strat? We didn't. New England did. I cried. So someone asked in the question, why did we put alternative defibrillation strategies? That was not our choice. That was New England choice. And despite me protesting that this should, this has always been dose VF, I wanted to be dose VF. New England felt it would have much more grab if we went alternate defibrillation strategies. So again, these are the things you give up when you're publishing in New England. So yeah, that's what happens. But when we talk about this, I never give a talk saying this is alternate defibrillation strategies. Everyone knows this is dose VF, and I get to talk as dose VF.
I made sure I put dose VF in our socials promotion for this.
Yeah, thank you so much. I appreciate it.
I just wanted to highlight before we wrap up, if there aren't any more questions, Sheldon, you're also the PI for CanRock, and Nova Scotia recently signed contracts to be a CanRock site, so that's pretty exciting. And over the next year, we'll be working towards contributing Nova Scotia cardiac arrest data to CanRock, which will enable us to do more observational research in Canada. I think also provide opportunities for paramedics to get involved in resuscitation research.
Yeah, and I think that's fantastic, Judah. We worked so hard with Nova Scotia to get them on board. I'm so excited. I've always felt Nova Scotia was a top-notch EMS system, and I think the ability to have them involved in randomized trials as well as observational research will be amazing. I just think it's a great service, and really happy to have them along. But I can just tell by the quality of the questions today, you guys are on the ball, and it's been an absolute pleasure to be invited to speak to everyone today.
Well, thank you for joining. It's been awesome to have you here. Do you have any last minute comments, Jen, or from others on the line in the chat or Q&A?
No, this was a great journal club. I was so pleased to be part of it, and thank you so much, Sheldon, for joining us.
Oh, absolutely a pleasure. Thanks so much to everyone. And if anyone has any questions, they, feel free to get hold of me at sheldon.cheskes@sunnybrook.ca. And again, be happy to get in touch with people.
Awesome. And if there's anyone interested in volunteering to do lead a journal club and do a critical appraisal, please reach out to Jen or I as well for that. So,
Thank you, Dr.
thanks again.
Cheskes. And
Yeah.
I didn't say it at the beginning too, anyone that's looking for CPNS information, you could claim this under Section 2, Group 2 Learning, which is 2 points per hour. Or if you're watching this video afterwards, it'd be Group 1 Self-Learning. We'll have it on the Pulse within a week or so.
Excellent. Well, thank you.
Thanks,
And,
everyone.
we'll take care.
Okay, have a great day, folks.
Thanks, Jen. See ya.